Welcome to the NRTRC's monthly open mic webinar for February. We appreciate you joining us and hope you continue to sign on for our monthly presentations. If you'll notice the different pods that we have activated, you'll see the pod with the list of attendees in the upper right corner. Below that is the file pod, which currently has a flyer for our upcoming conference that you can download, as well as slides from today's presentation. Below this is a links pod that can take you to the conference website, a survey we'd like everybody to complete on today's presentation, which I will also be having come up once Libbey is finished speaking, and a link to sign up to receive our newsletter, as well as other announcements if you'd like. If you have questions during the presentation, please leave them in the Q&A pod, which is directly below the PowerPoint. And if you have technical questions, please put those in the chat box just to the right of that. On the slide that's up right now, you can see our next webinar will be April 24th with Kim Schwartz. We are skipping the month of March due to the fact that our conference is that month. We also encourage you to take a look at the information on our conference website, as it is swiftly approaching next month and will be held in Portland, Oregon. With that being said, we'll move on to today's presentation with one of the NRTRC's past board members, Libbey Chuy. Libbey has been a telehealth coordinator for the Association for Utah Community Health since 2006, assisting FQHCs explore and implement telemedicine programs. She also sits on many regional and statewide telehealth and IT boards and initiatives. Since 2012, Libbey was also asked to lead Utah's patient-centered medical home practice transformation project. And on a more personal note, she loves being a mom to her 3 children, which I've met 2 of them, and they are beautiful children, and likes to be creative and write a Spanish blog. And with that, I'm going to hand it over to you, Libbey.
Right. Thank you for that introduction. And it's fun to see, I think, Kara and Joe. I know both of you. It's fun to have you on here, and also for those others who are joining us as well. And as I've told Martha before, I'm very familiar with this equipment. This is the same platform that we use here at our association. So if you do have a question as we go along, feel free to type that into the Q&A, and I will try to answer it as we go along instead of at the end. But I'm excited to be here today. I am a past board member. I got off because of growing family, 3 children that are super active. But I'm very involved still with the NRTRC and telemedicine, and I'm excited to share what we're doing here with community health centers. Today, I was asked to talk about, from Bob, to give an overview of what a community health center, that's CHC, and a PCA, a primary care association. Maybe you've all heard these acronyms or seen them around, but not quite sure what the role is and what they do. Also talk about the current landscape in terms of community health centers and telemedicine. Then talk about the challenges for implementing telemedicine in community health centers. And then I want to give you a snapshot of what current projects or current telemedicine we are doing here at AUCH, just to give you an idea of what you can do. So a primary care association, as it states there on your slide, we have funding that's authorized by Section 330 of the Public Health Service Act to provide necessary technical and non-financial assistance to potential existing health centers. And I'll talk about this in a little bit later, but for example, here at AUCH, we just assisted 2 new health centers prepare their data, do a large needs assessment, very comprehensive, write the application, and develop partnerships. And so this last year was a really great year for Utah. We got 2 new starts, so 2 new entire organizations and 5 new clinic sites. And we support them as they go along. We also are responsible for expanded services and support growth, enhance the operations and performance, support strategies to recruit and retain staff. And we'll talk about this in just a minute. And then starting here at the top of your slide, we'll just go around and talk a little bit about each of them. But the first bubble at the top, provide training and technical assistance. We have lots and lots of peer groups. I think we're up to 10 here within AUCH. Medical Directors Roundtable, Financial Directors Roundtable, a Billing Learning Team, a Quality Improvement Forum, a Patient Center Medical Home Practice Transformation Group, Outreach and Enrollment Peer Group. And so we have these peer groups that we provide training through those. We meet as peers from our different organizations and clinics to help and encourage them. We also monitor, going along clockwise now, monitor emergency primary care issues, and we expand services and support growth. What the example I just previously gave, we do lots of data polling, meeting with partners, staying connected. As in my position as the telehealth coordinator, I partner with lots and lots of people, try to keep afoot what's going on with Intermountain Healthcare here in Utah, with the University of Utah, with Utah Telehealth Network, to represent the community health centers in Utah, but help them also catch the vision of what is going on and what they can do. We enhance operations and performance. We support strategies to recruit and retain staff. We're eligible to help with tuition reimbursement for providers serving in medically underserved areas. Continuing up the left side, we assist with emergency preparedness. We have a staff member designated to do that. We support development of new health centers, as I've talked about previously, and we conduct statewide program assistance activities. Now moving on, so that's Primary Care Association, and I was going to mention in each state there can be one. In some states, a Primary Care Association represents a region or one or two states, but take a look. Most states do have one. Take a look. Who is your Primary Care Association of your state, and become partners and work with them to understand your community health centers even better. Moving on to a community health center. There's a couple points highlighted which are the essential, but health centers are nonprofit, private, or public entities, and they have to serve designated medically underserved populations or special medically underserved populations. So underserved or special populations. Here in Utah, under those special populations, we both have a migrant and seasonal farm worker community health center. We also have a homeless community health center. Not all of your states will have both of those type of health centers, of those special populations, but there will be community health centers. So here's just a national glimpse of what is going on with the community health centers. I know you can't see all the little details, but if you're sitting at a computer, which you probably are, feel free to go ahead and Google community health centers or federally qualified health centers in Utah or in Idaho or in Hawaii, wherever you're at, if you're not familiar with the community health centers in your area. And you'll be surprised maybe where they are, or maybe you know that community health center by another name and did not realize that it was a health center. Go ahead and Google that, and you'll be surprised. Here in Utah, we have 13 organizations with 39 clinic sites, meaning you can have one organization that might have 4 clinic sites. So we have grown so much in the last couple of years, but once again, we have 13 organizations with 39 clinic sites. Continuing just a little bit more on what is a community health center. They are private, charitable, tax-exempt, nonprofit, or a public entity. They must, once again, serve a medically underserved area, a medically underserved population, or be designated by the Department of Health and Human Services. You'll find them all in areas where there's a huge need for healthcare services. They also have to be open to all, regardless of insurance status or ability to pay. They offer a sliding fee discount that adjusts according to family income and a patient's ability to pay. And that income has to be evaluated annually, in some cases even every 6 months. They are not free clinics, but they are on a sliding fee discount based on their income. They are community-based and patient-driven healthcare homes that serve populations with limited access to healthcare. They provide very high-quality, affordable, preventative healthcare services regardless of their insurance status again. They serve as a part of the healthcare safety net with a mission to ensure access to quality care for the underserved. And they are also held to very strict accountability and performance measures for clinical, financial, and administrative operations by HRSA. Maybe you have heard the term UDS. That is stands for the Uniform Data System, and that is their it's been around for years and years, where they have to, that's what they are doing right now, submitting their UDS report, which takes into clinical standards, financial, and administrative. They have to pull and lots and lots of data to submit to HRSA. And then that is a public website that you can go and look at the UDS data for the community health centers in your area. Once again, you can Google UDS community health centers, and you'll pull up by state, by community health center. Community health centers also have to have a governing board. The majority, so at least 51% of those members, have to be patients at the health center. So that's really, really unique. If you think about maybe a homeless health center, once again, 51% of that community health center, of that homeless health center, has to have a seat at their board. And so it really is patient-driven care. They also have to have comprehensive health care and related services based on the needs of the community. So I like to think about the community health center. It is one-stop shopping. It is very comprehensive. Everything is under one umbrella, or some of these services can be contracted, but they have to be offered to the patients of the community health center on that sliding fee schedule. So you have primary health care, dental, think about that, all in one roof, behavioral health, pharmacy, lab, emergency care, radiology, transportation services, case management, after hours care, hospital specialty care, and translation services. And then also in the last, starting about 2 years ago, there's been an enormous push for them to be patient-centered medical homes accredited, which even increases maybe some of those after-hour care services and some of the other requirements that these community health centers are required to have. So now let's just move now down to Utah. This is a map of our of Utah and where our community health centers are located, the green dots. If you just notice at the middle of the map, right there by the big body of blue water, that's Salt Lake City area. So yes, we have a lot of health centers there around in this 100-mile range between Ogden and Provo. But then if you look down in the right-hand corner of the map, that is the Four Corners or Navajo Nation area. And we have 4 community health centers down there, and some of them are super, super remote. And then we have health centers of all ranges of size and impact. One of the health centers is called Green River Medical Center, and it's one of 3 of the smallest health centers in the nation. It's here in Utah, and it serves a very, very important role. It's an intersection of some major freeways, and they provide, all of them are, ready for those emergencies. So just some data so you understand what we're looking at here in Utah, and then once again, go ahead and look at that UDS data, Uniform Data Systems data, that you can find if you Google it for community health centers. But we serve about almost 374,000 encounters in 2012. The date is wrong there. With these 2 new organizations, the 2 new starts, we estimated about 30,000 more. So we're looking at about 400,000 encounters for this next year. That's the estimate. Most of ours are urban encounters, but we do have a large impact in the rural. Our patients, this is 2012 UDS data, so Uniform Data Systems data. 82% of ours are white, and you can see the breakdown there on the slide. And though of those white, there's white Hispanic and black Hispanic, so about 46% of our patient population, though, is Hispanic. So we're predominantly English, Spanish community health centers. Once again, depending on where you're at and who you're serving, your populations vary tremendously. Once again, look at this, the patients in poverty level, 74% at our 100% and below And then just thinking about your own healthcare system that you work in, maybe in a hospital or another clinic, and comparing these populations to who you're currently seeing. Once again, this is just our patient makeup. Our uninsured, 57%. This is statewide. 57% is uninsured, and we'll talk about this a little bit more in when we talk about payment. But that becomes a hurdle as we look at telemedicine. But once again, health centers have to be open to all insurance types and also be able to pay on a sliding scale. So telemedicine and community health centers, what's going on? As all of us know, there's lots of going on in healthcare, lots of movement, and community health centers are set to the same requirements. We launched a patient-centered medical home initiative about 2 years ago. HRSA incentivized community health centers to become PCMH, and it's expected in the following years that their funding and additional grant opportunities will all be linked to if they are PCMH certified. 9 of our 11 from last year, 9 of the 11 are PCMH accredited here in Utah. We have 2 more that will be by the end of 2014, and then we have the 2 new organizations that we will help catch up in the next year or so. But we have really pushed for them to become PCMH, and that brings in, once again, that team-based care to provide whole health, meaningful use, accountable care organizations, and then also the Affordable Care Act. A lot of community health centers received additional funding this last year to help with outreach enrollment. And with the ACA, it's changing the landscape on where patients can go, what they can choose. And so that's changing the options for community health centers as well. A couple of resources. One of these is linked down in your web links there on the right-hand corner. But NAC is the National Association of Community Health Centers. And I think they're starting nationally to embrace telemedicine within community health centers. There's more resources, there's more attention at national conferences, there's more papers put out, white papers and information, webinars on it, and all that information can be found at this link there at the nachc.com/telemedicine website. And once again, that's the National Association of Community Health Centers. And then also FQHC sometimes is linked with the word CHC. FQHC is Federally Qualified Health Centers, and that really refers to a payment system. Community health centers are reimbursed at a different level in Medicare and Medicaid, and that's the FQHC and reimbursement. Once again, you can take a look at that for reimbursement issues. And then funding opportunities. This is just one that just came out just a couple of weeks ago. As I said just a few minutes ago, nationally, telemedicine is starting to be integrated more and more into the opportunities that we have coming out. Into PCMH, it's talked about quite clearly. It's talked about at our National Community Health Center conferences. And then this last funding that just came out 2 or 3 weeks ago, it's a mental health service expansion grant for community health centers. And in it, it talks explicitly about using telemedicine to do behavioral health. And so that grant is due mid-March. If any of you are doing telemental health in your areas, and you can provide that services, go ahead and reach out to your community health centers. Maybe some of them are applying for this, and that's a great way to make that partnership, to connect with them, at least show that, I don't think telemedicine is the only option, but it is a option that works really, really well. And so it's something that you can bring to the table and say, this is how we can partner, and this is what we already provide, and it might be more cost effective, and it might be able to reach more people. So once again, that is a funding opportunity that you can provide. But they're continuing to come out, and I have seen just a slow increase of telemedicine mentioned in a lot of these. So challenges, let's start with reimbursement. I think reimbursement is a challenge for anyone working in telemedicine. It's not unique to community health centers. However, if you think about our patient population, and this might be slightly different than other states, but we are sitting at about 51% uninsured. And if you think about if, whatever telemedicine program, if already half your population doesn't even have insurance, and then there might not even be reimbursement for telemedicine, it makes it both easier and more challenging to set up a program. We have, for all of our telemedicine programs, done fee for service. We've contracted straight across and avoided the reimbursement, except in a few simple cases. That allows, for the provider coming in, telemedicine might be new for the provider, and we have to catch the vision, help them catch the vision. So they get paid even if there's no reimbursement, but then it opens up opportunities for those patients that might not have those specialty services. Reimbursement, once again, is tricky for anyone involved in telemedicine. The rules are varied state to state, but just once again, keeping in mind for community health centers, you are accepting a high rate of uninsured patients. And so how to incorporate them into that payment. And then also balancing federal requirements. Community health centers, they are working on a shoestring budget and have so many requirements, data that they are held accountable for. Like I said, they are pulling their uniform data system, their UDS report right now. And that's very, very time intensive. And if you're a very small clinic and an organization and you maybe have 8 to 15 staff members total, and you have to take 40 to 80 hours to pull this report. Sometimes trying to work on telemedicine or an extra project is just challenging. Also, just once again, is serving underserved populations with limited funds. It is a challenge. They work on a shoestring budget. They have really, really underserved populations they're working with, but it's wonderful and very rewarding work. And it's the populations that might need these services the most. So now I just want to switch and give you a snapshot of what we are doing here at AUCH to give you maybe some ideas and also help you be able to network with your own primary care associations. The first bullet or the first point is we have had a dedicated staff position here for 10 plus years, which is really, really unique actually. I've tried to reach out to other primary care associations multiple times, and even in preparation for this webinar, trying to make contact to at least provide a list for those listening. And in the Northwest, in this Northwest region, not a single other primary care association has a dedicated staff position for telemedicine. And so that's challenging. Maybe they don't know what it is or what to do with it. And so if you do want to reach out to a primary care association, I think the first task will be to help that staff or that team understand what is telemedicine, how it can benefit their members, help them network, help them catch the vision. So then in turn, that primary care association can market what you're trying to do to its members. We've also had a very innovative leadership. I've had great executive directors here who caught the vision of telemedicine really, really early, more than 10 years ago. And it's been great to have their support. Once again, that just kind of falls under that first point as well. We've also had a long-term relationship with the Utah Telehealth Network. I believe Patricia's on here today, and we've done many, many projects together. They've been great to work with. And so I think that's been really unique as well, that we've been able to tackle telemedicine together on a lot of things. And I've had another person to talk to. So once again, forming those relationships, forming those teams, helping the primary care association, the community health centers understand what you can provide takes time. And then we've just continued to expand telemedicine services and programs little by little, year after year. So it's been great to see it grow. So a couple of programs, or the programs that we currently offer here at AUCH, are our retinal screening or our teleophthalmology program. That probably started about 8 years ago, and I'll talk in more detail just about that one. Our teledermatology program, the platform is built, the provider is identified, the paperwork's in. It's just, we'll probably be launching it hopefully by June. As you all know, telemedicine projects take longer than we all expect, but we're hoping telederm is by the summer. Project Echo, which there's a similar program out of New Mexico. Utah started one a couple years ago, and many of our members are connected with the Project Echo, and it's been great. It's a provider-to-provider e-consult type of telemedicine. Telebehavioral mental health. Already, some of our community health centers are providing telebehavioral health. However, from the primary care association level, we are looking at adding telepsychiatry, and we'll be looking at that in the next couple of months as well. Medical Spanish for healthcare professionals. We provide an 8-week course for the staff of community health centers. Kind of Medical Spanish 101, since we have such a large population. It is web-based, it is video conference, Polycom based, and it's open to others outside of Utah. If you're interested in that, let me know. It's an 8-week course. Telepharmacy, we have several of our community health centers that participate in telepharmacy, like the candy vending machine type of format, as well as doing consults from clinic to clinic in telepharmacy. We do not support that from the PCA level. Teleradiology, all of our sites have teleradiology. We also provide diabetes education for patients. It's currently not active because our Spanish-speaking diabetes educator has left. So if anyone is providing diabetes education in Spanish, we would love to partner with you as well. That is a huge need. And we did group visits through video conferencing, and it worked very, very well, and was a great resource to our patients. We just finished a remote monitoring project with the Utah Telehealth Network, and had great results. And actually just yesterday, our state health department released some additional funding to do a very simple remote monitoring project. So there's some funding for 2 or 3 community health centers to continue some remote monitoring on a very lower level, but continuing that and jumping off the success that we had with our grant with UTN. We also in the past have done several different text messaging platforms, which I know in the telemedicine world sometimes is not considered telemedicine. I think those two worlds are mixing even more so. And now with patient portals and with cell phones and smartphones just exploding, I think the two worlds are even going to intersect even more and more. And so finding ways that we can provide telemedicine through your smartphone, being able to communicate with your provider, which is a key component of patient-centered medical home, being able to provide constant communication with your team of care. And that is what we're doing currently at AUCH. And then we're also, like I said at the very beginning of this webinar, we provide lots of trainings, technical assistance, peer learning groups, the basic medical Spanish course. And we use, like I said, this Adobe Connect and our Polycom system very regularly. At AUCH, for our technology, what we use, we are on a shoestring budget as well. We don't have fancy equipment, but we use Polycom equipment. It's old, but it works. And we use Adobe Connect for webinars and peer groups. And then just this past December, we completed and released our telemedicine platform, and I will show you a couple of snapshots of that. We are very excited, and this platform was built for all of our store and forward programs. So currently, if you remember, we only have our teleophthalmology program. We're ready to launch teledermatology, and then who knows, other store and forward type of components maybe down the road. So our Telemed platform was released in December. It's HIPAA compliant, security certified. It has the 7-year storage component. An organization can create multiple logins. We went this route because it was less expensive. We wanted a way to share images. Community health centers are individually owned, operated, public or private entities. They're not one huge system, even though we'd love them all to be connected. And so they're not sharing, they're not on the same EMRs oftentimes. And so we needed a way to share images, and we didn't have the funds to purchase a PAC system outright to, the major image storage systems. And so this was a great way for us to be able to have a platform. Organizations log in, they upload their images. A provider who's reading the images also has a login and can view those images and send back a message or a management plan. So this is our platform, and it does not match our current logo because we just switched just a couple of weeks ago, but we'll get that soon. And this is just a snapshot. It's built to support both the retinal and dermatology initially, and then we'll be able to add additional specialties as we need them. In our program, we have currently 11 retinal cameras. We're actually looking for a couple more right now. We only have one retinal provider, which he can keep up with the demand, currently, but there's room to add additional providers as needed. We're on our 10-year anniversary this year. And we provide, at the Primary Care Association level, we provide annual refresher courses, on-site technical services. We help our members, our community health centers, look for funding to purchase the equipment, to train them on the platform, on how to take imageries, reconnect them. I was just on the phone just before this webinar with the tech from one of our camera providers, companies, with one of the community health centers. So we help them troubleshoot and make sure that the program, and then we run the data reports as well. So just a look at what we've been doing on our growth of the program, and I just get excited. I mean, there's lots and lots of room for growth. We serve a lot more than 1,300 diabetic patients, but it's just exciting to see how little by little the vision of telemedicine is captured, how the program is integrated into their delivery of care for diabetes, how patients increase their understanding that they need this service, how medical assistants know how to refer, and so the system just gets better and better on how to integrate retinal screening, teleophthalmology services into their clinic. And so we expect, if you just watch maybe 1,500 patients this next year. And then community health centers, just so you understand the funding and finances. So you can self-pay. Once again, they uninsured patients below the 200% of the federal poverty level pay on a sliding fee scale based on annual income and the ability to pay. And once again, that documentation of income is required on an annual basis. They also accept Medicaid, CHIP, Medicare. They support or accept private insurance. Just like private practices, they receive part of their funds from a federal grant. And then they also rely on community support. Our community health centers here in Utah, all of them receive some community support, and each of them are unique in how they work out the details. Some have contracted with some of the major healthcare systems in Utah. Others have partnered with major employers to provide primary care services to that employer and on a fee-for-service rate as well. And then just wanted to open up for some questions. I know this is a good overview, and then you might have some additional questions on how you can partner with your community health centers or primary care association. So I'm open for questions or to try to tackle anything that you might want to know.
If anybody wishes to leave Libbey a question, they can use the Q&A pod below the PowerPoint presentation. Libbey, it looks like Jonathan's asking, is telemedicine reimbursed at PPS rates or CPT code-based rates in Utah?
And what I understand, it's CPT code rate in Utah. We have a billing specialist here on our team, and so I refer a lot of my questions there, but we always pull the CPT codes. And Jonathan, if you have, I can follow up with her specifically and ask her about that.
Okay, any other questions for Libbey? Oh, hey Libbey, are you able to see the questions?
I am not.
I think in the top of the Q&A bar, there's 2 little people symbols, and I think you have to switch it to the other symbol, if that makes any sense.
Yes. So Patricia, I see your question about mental health next week. Okay, perfect. I can follow up with you next week. And Jonathan, I will ask our billing specialist here and get back to you on that question to clarify.
Okay, and any other questions for Libbey?
How are you financing Echo? Sorry, let's read that. Sorry, I missed this earlier. Cara, the Project Echo program is coming out of the University of Utah, and I believe, I don't want to misspeak, but I believe there is a line item in the university's budget for that currently, but they're looking. It's not our program, we just partner and use their services, but it's not our program currently. Well, I mean, it will never be our program, we just partner with them, but I believe that's how they finance it, and that they are looking at other ways to keep it going. Oh, are there other questions? Sorry. Oh, okay, now I see the questions coming. It is not reimbursable yet in Utah, and Patricia's typing in, Suzanne is the project manager for Project Echo, and I can also send that out to you, Cara, as well. Maybe if you even Google it, it might pop up with her email. There you go. Thank you, Patricia.
Libbey, do you want me to?
Question?
Oops, sorry. Do you want me to put that contact information in the chat box so that Cara can get it?
Oh, sure.
I don't think that she can see it.
Oh, here. I can type it in. Thank you, Patricia. Perfect. Well, perfect. Any other questions?
Okay, well, thank you very much, Libbey. That was great, and I'm going to put up a survey if everybody could please take that so that we know how we're doing on our monthly webinars, and if you have suggestions for topics that you'd like to have in the future, or if you have suggestions for speakers, anything like that, we really appreciate the feedback. And
thank you, Martha.
Yeah, absolutely. Always happy to have past board members do things for us. And thank you to everybody who attended.